Okay. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. And good afternoon. So we frequently come across these so-called bundle branch blocks on ECGs, and they created a lot of puzzle and diagnostic dilemma in our daily clinical management. So let's chat about it. Um, like this case, this 37-year-old man presented to the ED with chest pain, and his ECG is like this. Um, what is this? So obviously, this man is in sinus rhythm, and he has got right bundle branch block on the ECG. We can obviously see this, and anyone should know that the man has right bundle branch block with the right axis deviation. And another case, young man referred with palpitations, and we can see immediately again he has got the right bundle branch block because the RSR pattern here on the B1 and also the um, S wave on the B6, and he has got quite a lot of these ventricular ectopics, BEs, and again this axis is rightward. So what is this bundle branch? So we all know very well that after the AV node, so there is the next conduction pathway is the his bundle. Then you have got the right and the left bundle. So the left bundle is further divided into the anterior and posterior fascicle. Then down further into the small bundle, which is called the Purkinje fibers. So they all are basically the conduction system in which all the impulses will pass. When there is one situation in which uh, there's a block to the left bundle, so what will happen? So in normal conduction, the impulse travel down the left and right simultaneously, and the septum is activated from the right to left, sorry, from left to right. So that result in the small Q waves in the lateral leads. So in left bundle branch, so what happened that there is conduction delay to the left bundle, so the impulse will travel via the right bundle branch to the RV and then to the LV. So this is the opposite now than normal. So septal activation is reversed. Okay, so that's why you got the lateral Q waves. The depolarization vector from right to left ventricle will produce the tall R wave in the lateral leads, right? Which is the V5-6 and also lead 1. And also deep S waves in the right precordial leads. So this is in left bundle branch. So in left bundle branch, typically you see deep S waves in the uh, V1 to V3. Okay, and then the on the lateral waves, you see the R waves, big R waves on the lateral leads. So there is the M shape, or we call it rabbit ears, on lateral leads. And because of the delay in the overall conductions, remember that in bundle branch, there's always going to be a broad QRS. So in this case, the QRS duration is 120 milliseconds. On the other hand, in right bundle branch block, then we know what happens. So look, you can see the pattern here where what we call the RSR pattern on the right precordial leads. So in this case, there is the opposite from what happened to the left bundle. Impulse travel from in this case, the left ventricle is activated normally, whereas the early part of the QRS complex to the septal depolarization is unchanged, but there is a delayed activation of the right ventricle. Okay, and because of that, so there is a second R waves, which is the R stroke. So then you get a tall R stroke in the precordial leads, and there is also a slurred S wave. So that's what we call the RSR in B1, and while in the B6 you got the big S waves. So in this case, normally the cardiac axis remains normal. So this is in summary. So that's the pattern is in bundle branch. Basically, you got in B1, B2 upright, but there is the RSR pattern, and there is S wave in the B5, B6. While in the left bundle, then you get the uh, big S wave in the right precaudal leads or B1 to B3, and then you get the M pattern or the broad QRS and the toe upright R in the lateral leads. Then you have this two situation in which there is the left anterior fascicular block, which is this one, or the posterior fascicular block, which is this one. Then they result in different patterns. So in the LEFB, then you get the left axis deviation, while in the posterior fascicular block, you get right axis deviation. I won't talk any further on that. That's the detailed uh, domain of the electrophysiology. So let's just make things simple. So just remember this. What are the causes of bundle branch blocks? So right bundle branch block can be normal in young, tall, thin people. Just a simple math. Um, right bundle branch block tends to be more of the normal compared to the left. It can be idiopathic, and remember one big thing, it can be due to the right ventricular strain, as for example in PE or in chronic respiratory disease. But it can also be present in ischemic heart disease or myocarditis. Whereas left bundle branch block in general is usually abnormal. It almost never present in normal person. So it's associated with many things like ischemic heart disease, hypertension, LVH, aortic valve disease, sometime after valve replacement. And remember, pacemaker, RV pacemaker, most pacemaker is in the right ventricle, so you get left bundle branch block automatically. If you get RBB with pacemaker, then you're talking about something else. That is something unusual. Then you also get myocarditis, gives you right or left bundle branch block, of course, and also cardiomyopathy. So the RBB, this is what? Is it left or right? So again, you go by the maths just now. Because when you see the tall R in the right precordial leads, then you cannot be talking about the left bundle branch. So this is right bundle branch, but not very broad QRS. So RBB may be normal variant, especially if the pattern is present but with the normal QRS duration. So remember, you will see the RSR and a little bit of S wave laterally, but not very broad. So like this, basically it's a normal variant. So nothing to worry too much about it. Um, if not, then it could be due to abnormality of the right side of the heart, because that's what RBB will reflect on. So if you see RBB white complex RSR pattern in the V1 and then this deep S wave in B6, so this is a complete RBB. Like this one is incomplete because you don't see so much a deep S wave in the V6, right? But you see even the RSR pattern is not that obvious, but there is upright, tall R waves in V1. So this is incomplete RBB, and in fact, the QRS duration is also somewhat less than 120 milliseconds. But this is not a normal connection. This is RBB, but it is partial right bundle branch block. You can see the axis also is changed, right axis. And of course, this is not a sinus rhythm ECG. Mind you, you don't see the P waves. Actually, there's like a retrograde P waves here. This is a junctional rhythm. Try me. Yes. How about this one? So what you're talking about, is this right or left? So again, always look at the precordial leads. So in this case, you look at the precordial leads carefully, so you see upright R waves in the V1 and 2. So this is already belongs to the right block. Okay, so this is right bundle branch block, a broad QRS, and you see the, no, you don't see that obvious RSR, but there is a blip of R on, up right here, and then you get another R here, and then you got deep S wave. So this is a right bundle branch block. What else you have? you have this left axis deviation. So this is what we call the bifascicular blocks. Now, how about try me on this? This is, look carefully, because this is one of the so-called, normal LBBB. I mean, this is where you see normal LBBB, because one of the etiology of LBBB, as we saw earlier, is the ischemic heart disease or acute MI. So we will be talking about that shortly. So before we look into that, look at this ECG of left bundle branch block carefully. This is the usual pattern. So when you see left bundle branch, then you see the Q waves. So called you actually, this is S waves, not Q, because this is the last deflection. So your last deflection on the right precordial leads on B1 to B3. So huge S waves, right? So when you get huge S wave, then it will be accompanied by a discordant. We call it discordant because it's the upstroke now, or creating the so-called ST segment. So that is an ST segment elevation. So this is a big ST segment elevation, but it won't be not much more than 5 mm. Hopefully, so we see that. um, there's no other associated pattern. So at the discordant leads, you call it discordant lead, so there is ST elevation. But when at the concordant lead, there is ST depression. So where are the concordant leads? The lateral one, this is lateral one, this is concordant leads. Concordant because this is the QRS is upright, and then it will be followed by the ST depression. So this is the usual pattern in the left bundle branch block. Observe that carefully, because then you will see the unusual pattern, which means something. And that's all what we want to know. So LBB, so this one I skipped, we already talked about it. So then there is the fascicular block. As we know, the anterior fascicular block basically usually associated with the left axis deviation, and then the posterior fascicular block associated with the right axis deviation. I think we go as far as that. And then you have the bifascicular block, as what we said just now. We have the usually the left axis deviation with the right bundle branch block. So you will see the both, there is right bundle branch, also the left axis deviation. But then you will have different other situation like the trifascicular block and so on. And bifascicular is already very serious, because patient may go into complete heart block soon, because they are only relying on one other fascicle, which is the posterior fascicle in this case. Now, this is a very important slide. What the European Society of Cardiology said about bundle branch block and MI. And remember, whatever you see, patient with chest pain, no chest pain, left bundle, right bundle, is it MI or not MI? So this is important principle. So number one, in the presence of left bundle branch block, the ECG diagnosis of AMI is difficult but often possible if marked ST segment abnormalities are present. So there is LBB and maybe is MI if there is a marked ST segment abnormalities, very marked. Okay. And then there's somewhat complex algorithm has been developed and suggested, like the Scalbosa and so on. But is it so reliable? So ESC said simply, yeah, there is something like that, but the diagnostic certainty is a little bit doubtful. So it's useful, maybe very useful, but then do not rely on it completely. So when you have concordant ST segment elevation, okay, which is in the leads positive QRS, okay, is one of the best indicators of ongoing MI. So concordant ST elevation. That means the QRS upright and there is ST segment elevation in LBB, that is MI. Okay, and then patients with a clinical suspicion of ongoing myocardial ischemia and LBBB should be managed in a similar way to STEMI patient. I mean, send them to cath lab. Okay, but it's important to remark that the presence of a presumed new LBB does not predict MI per se. So patients with MI and right bundle branch block, remember, MI with right bundle branch block have a poor prognosis. So it may be difficult to detect the transmural ischemia in patient with chest pain, but in this case, primary PCI strategy is recommended. So now remember the rule. Relate with the clinical presentation. Always treat the patient, not ECG. Repeat ECG at intervals to see progression. Okay, repeat ECG. And then remember the role of biomarkers. Maybe echo might help you. And angiography may be safer because then you are looking at the coronaries, then you can treat straight away. So here is what it said about bundle branch block. Concordant ST segment elevation more than 1 mm in leads with positive QRS complex or concordant ST segment depression in V1 to V3, then these all are telltale signs of STEMI. And you have discordant ST segment more than 5 mm elevation in a lead with negative QRS complex. Then these are all talking about the skull fossa, okay? And then there is ventricular pace rhythm. It may still be possible to diagnose MI. It's RBB and it could be MI. So in this case, it's right bundle branch block. It doesn't stop you diagnosing MI because here you can see the ST elevation. This is um, anterior anteroseptal MI, and it is a serious, extensive anteroseptal MI. You can see the progression of the ECG here, much bigger elevation than that has confirmed, and patient has got occlusion of the LED. And in a similar way, you can see here, initially you see a bit of tall tentative waves, and then you develop into this, you look at this V5, especially V4 to V6, you can see a kind of ST elevation. Then don't wait. And if the patient has got chest pain, then it is reasonable to assume, yeah, this is ischemic chest pain, because the patient later developed full-blown ST elevation everywhere here in the precordialis, large septal or anterolateral ST elevation MI. But then sometimes there is a little bit of ST elevation and it's rate related. In this case, initially it's RBB, but here it's changing to AF, atrial fibrillation, fast atrial fibrillation, RBB. This is not MI. This bit of ST elevation, but it has been present in the initial ECG. So this is basically is MI from the troponin rise, but there was no occlusion of the coronaries. LBB. So this is again the usual pattern LBB with the discordant ST elevation or the discordant ST depression. Then you see new or old. So there's something of a discussion. Is it new or old? And sometimes or having the old ECG might be good, but one fact there is that LBB may mask actual ischemic STT changes. So a new LBB in patient with just chest discomfort implies a relatively high probability of acute coronary occlusion. So this patient should be managed like STEMI. So LBB with chest pain, then managed as STEMI. Okay. So there is no previous ECG, then assume this is new changes. But the patient must have chest pain, not just anyone walking to you with LBB, right? So what is the caveat here? A significant proportion of left bundle branch blocks are not new, but simply due to because it's new to your hospital. Okay, so even if the LBB is new, the occlusion may not be total. So it may be there may be occlusion, maybe stenosis, but it's not occlusion. It's not really a cause of the problem. So they say that only 5 to 20% maybe is a real MI. So majority not. Okay. So in this case, PCI doesn't confer benefit. So now this is we talk about the Scarbosa criteria, and remember Scarbosa criteria is used for left bundle branch block and not right RBB. Remember, so in the presence of left bundle branch block. So first criteria is 5 points, the biggest one, which is concordant ST segment elevation. Then if more than 1 mm in the concordant leads, that means upright QRS, then this is strong predictor of MI. Or the other way is concordant ST depression. Sorry, discordant ST depression. In the lead V1 to V3, they just call it lead V1 to 3 because usually in here you got ST elevation, but instead you got ST depression in V1 to V3. That is a good predictor of MI. Not very strong. And then you got marked ST elevation, discordant leads. Then in this case is V1 to V3. That's also predictor of STEMI. But so they said this is after they look and study, not good enough. So it changed there is a modified Scarborough criterion. 1 and 2 is the same, but the third one, which is the excessive ST elevation, but they change it. It can be excessive ST depression or excessive ST elevation, but it use the percentage more than 25%. So you make calculation here, well, how much ST depression proportionate to the upright to the discordant lead. So then you calculate is more than 25%, then it is positive for STEMI. Similarly with ST elevation, discordant ST elevation, then more than 25% is positive. Simple, right? Something to remember, simple. So is LBB, is MI, so we call what, where is it? So here is the LBB, that's the usual LBB. So where you find the, remember that again we said about the discordant ST depression. So here we have the discordant ST depression in the anterolateral lead. So this is positive for MI. And here is the first one. So here we actually, this is, oops, sorry. It's a normal pattern again. Okay. So here you have the discordant ST elevation or concordant ST depression. So this is not MI. So remember this pattern. Now we talk about this. Look at it. Changes. There is the ST depression here, which is the concordant or discordant ST depression, so which is negative, or the discordant ST elevation, which is negative. But here there is a concordant ST elevation. That means as QRS up, but there is ST elevation. It's quite small, but you can see in both leads. So this is positive for ST elevation MI. And here is a different appearance. Patient is actually having a ventricular pacemaker, pacing and his left bundle, creating left bundle branch. But now we see this in V1, V3, V1 to V4 especially. There is a large ST depression. Because you remember, in LBB, usually in V1 to V3, there is the large ST elevation, but here instead ST depression. So this is actually resembling a posterior MI, isn't it? And indeed, this patient has got a posterior STEMI, a posterior occlusion of the left circumflex artery. So this is a true MI in the presence of left bundle branch. So got it? That's as simple. Just as a conclusion again, I repeat what the ESC said because this is important. In principle, okay, LBB can still diagnose MI, but it's difficult, but often possible. Okay, often possible. So there is algorithm, but do not rely completely because they do not provide diagnostics. You can use it, but do not rely completely on it. Just again, use your clinical judgment. So concordant ST segment elevation is a strong predictor, one of the best indicators. So the upright QRS and the positive ST elevation, that's almost confirmed MI STEMI. And in patient with suspicion of ongoing myocardial ischemia, and LBB should be managed like STEMI. I mean, aim to send them to cath lab, okay, and presume that LBB is new, provided the patient has got symptom, chest pain. So the right bundle branch block could be a poor prognosis for patient with having MI. So in RBB, you can still diagnose ST elevation. So if it is present, that means it is a poor prognosis, then you have to aim for PCI, immediate PCI strategy. So that is in conclusion, treat the patient clinically, and remember, you can still diagnose ST elevation MI or MI in the presence of bundle branch block, but be careful. Use an overall approach in making a judgment, and you will be most likely right. But of course, treat the patient clinically. Do not just treat the ECG. Thank you.